होता येत नाही आहे. हॅलो. Good evening. Again, we are here on 1st of April for our journal journey. This program was initially started by Raigad IIP and it was very successful, and then it was also taken in collaboration with Maha IIP. First, may I request Dr. Hemant Gangolia sir's blessing for this episode of Journal Journey. If possible, sir, share few words for us. I think, sir, is...
Hello.
Yes.
Hello.
Thank you, sir.
Can you hear?
Yes, sir.
Thank you, madam. Thank you, madam. Because I'm traveling, all the best wishes, and I'm sure that this episode will be a successful one, and we will learn a lot of things from this. And all the best to the guests, our presenters of both the cases. I also welcome our expert, Dr. Kabra sir, and our mentor, Dr. Imen Monti sir. All the best, sir.
Thank you. Thank you, sir. Now, may I request Raigad IIP President, Dr. Pramod Wankhede, sir, to say a few words.
Thank you, madam. Welcome all and good evening to all. आणि नवीन वर्षाच्या शुभेच्छा सुद्धा गुढी वाढवायच्या. This program is really fantastic, a very academic program which takes us back to our PG days when we used to present articles from journals for discussions. And here we get opportunity to hear an expert like Kabra sir. So I congratulate and best luck for both the presenters. Thank you very much.
Thank you, sir. May I request our past Joint Secretary, Dynamic, Dr. Sanjeevani More, and she is also interested academically and very much attached to Journal Journey. So I will request her to welcome all the guests as well as dignitaries. Dr. Sanjeevani.
Thank you so much, ma'am. Good evening, everyone. On the behalf of IIT Raigad and Maha IIT, I welcome today's guest of honor, Dr. Ramakant Patil sir, who is organizing chairperson of Mahapedicon 22 Nasik. Dr. Kishore Kabra sir, who is expert neonatologist. Dr. Nimai Mohanty sir, Professor MJM Karamboli. Dr. Hemant Gangolia sir, who is the president of Maha IIP. Dr. Samir Sadavarte sir, EB member Maha IIP. Dr. Pramod Wankhede sir, who is president of Raigad IIT. Dr. Jai Bhandarkar sir, who is state convener of Maha IIT. Dr. Vikas Mode sir, who is vice president of Raigad IIT. Today's speaker, Dr. Amruta Vagiskar ma'am and Dr. Ann Thomas ma'am. And our respected Chitra Kulkarni ma'am. Welcome all. And respected seniors, colleagues and friends from all over Maharashtra. Welcome. Today we are here on digital platform for our monthly journal club, Journal Journey, an initiative by Raigad IIP with Maha IIP, collaboration with Maha IIP, under guidance of Mohanty sir, Gangolia sir, and Bhandarkar sir. We successfully completed 1 year of this journal club, which was huge success. Beauty of this club is we can interact with all experts throughout our Maharashtra and upgrade our knowledge under guidance of expert seniors. Now I will introduce today's guest of honor, Dr. Ramakant Patil sir, who is a senior pediatrician and organizing chairperson of Mahapedicon 22 Nashik. Sir, kindly give your blessings for Journal Journey. Over to you, sir.
Raigad IIP and Maha IIP for giving me an honor to be a guest of honor for this Journal Journey. It is rightly said that it is a journey, Journal Journey. And after our college days and postgraduate days, it is really we do not get time, even physical journal or e-journals. Very rarely we look whenever there is a difficult case. But if we start this proactive, here in Nasik, 10 years back, we used to meet every week on Thursday for Journal Club. But it did last only for 3 to 6 months. This is an excellent initiative by Maha IIP and Raigad IIP. So many innovative ideas are there, and it definitely gives a nostalgia how we used to search the journals. Now the things are different. We are getting at the tip of finger. So many journals are there, but still we do not get the time. So this becomes a compulsively attending the journal club. And at the same time, there are stalwarts from the our field who can advise us and give a different perspective and simultaneously different papers on the same topic. So, respected Dr. Mohanty sir is there. Then today's this thing expert, Dr. Kabra is there, who is a big name in neonatology in India, and President of Raigad IIP, Dr. Wankhede. Then today's speakers, Dr. Amrita Bhaviskar and Dr. Ann Thomas. I wish them all the best, and they will definitely bring to add something in our knowledge, because whatever is already known about neonatal hyperbilirubinemia, mania, they will also add something new, and whatever new thing is there, and Dr. Kabra will elucidate it further. I wish all the best for the journal journey, and let it continue by Maha IIP and Raigad IIP in future also. Thank you for inviting me and also giving me time to interact with you all. Thank you, ma'am.
Thank you so much, sir. Now, may I request Dr. Chitra Kulkarni, ma'am, to moderate this session. Over to you, ma'am.
Yeah, with little initial glitches, really we are very, very fortunate to have so many dignitaries with us today. May I request State Convener Dr. Jay Vandarkar to introduce today's expert, Dr. Nandakishore Kabra, sir. Dr. Jay?
Yeah, are we posting the slides?
Yes.
My host, Madam the Colonel, share.
Pallavi, Madam.
Thanks, धन्यवाद. सगळ्यांना मराठी नववर्षाच्या शुभेच्छा well in advance. And we started this 1 year back on Doctor's Day, and this journey is I think very well appreciated, as well as very good responses there. And I thank all of you for present in large number, as well as I thank I was privileged to have introduced our today's expert, Dr. Nandakishore Kabra sir. He doesn't need actually any CV to explain to other all of present here. His MBBS, MD, PED, DNB, DM Neonatology, and MSc in Clinical Epidemiology and MNS FAP. He's a director of Neonatal ICU, Surya Hospital, Mumbai, and a very well-known academician as well as well-known neonatologist, and very good at that statistics of all this clinical epidemiology. So thank you, sir, for giving your precious time for this important our event of Maha IIP. And I again give all the best to both presenter, Dr. Amrita and Dr. Ann, for today's presentation. Thank you very much. Over to Chitra Madam again.
Yeah, please also introduce our first speaker, Dr. Amrita Bhaviskar. Slide, please.
Yeah, again, I have a very good chance to introduce this smart pediatrician from Thane, and she's the secretary of IIP Thane, consultant pediatrician and neonatal and pediatric intensivist. She works at the Shashwat Specialty Clinic, Siddhivinayak Hospital, Thane, and I met her again physically at Navi Bombay, this I think installation ceremony, and I think she will present very well today. So again, all the best to her. Thank you.
Over to Dr. Amrita. Please share your slides. All of them have prepared very well. And the enthusiasm is infectious.
Give me a minute, madam. Just sharing. Good evening, madam. Is it visible?
Yes, ma'am, it is visible.
A very good evening to all the dignitaries, and thank you, Maharashtra IIP, for the wonderful initiative. Today, I'm presenting an article published in the Journal of Perinatal Education in the year 2020. It is a systematic review, a role of kangaroo mother care in the management of neonatal hyperbilirubinemia in both term and preterm neonates. Neonatal hyperbilirubinemia is one of the most common clinical signs in the neonatal practice we come across, affecting 60% of the healthy neonates and around 80% of the premature neonates. Harmless otherwise, but high levels of bilirubin, unconjugated bilirubin, is neurotoxic, can cause cognitive risk, resulting in lifelong morbidity. Phototherapy being one of the most conventional treatments being practiced in the present day. Recent studies to evaluate the role of probiotics, prebiotics, and massage therapy, including KMC, have been tried. Kangaroo mother care. Principle of it. Thermal care through continuous skin-to-skin contact. It helps in supportive exclusive breastfeeding or other methods of feeding. Early recognition of illness and response to treatment is noticed. Decreases the risk of sepsis, hypothermia, hypoglycemia, hospital readmission, increase in the exclusive breastfeeding are the few advantages. Also, helps in increase in enterohepatic circulation. It decreases the enterohepatic circulation by early passage of the meconium. As we all know, that our conventional treatment in the form of phototherapy has this adverse effect in the form of hyperthermia, dehydration, hypercalcemia, watery diarrhea, purpuric eruptions, childhood asthma, and infantile cancer. Whereas the advantage of the kangaroo mother care has shown improved outcome, reduced hospital stay, reduced parental anxiety, and reduced economic burden to the society. Subject of the study was, can KMC, when combined with phototherapy, be advantageous to elevate unconjugated neonatal hyperbilirubinemia early? Hypothesis was, KMC, when combined with phototherapy, is advantageous to elevate unconjugated neonatal bilirubin early. Whereas the alternate hypothesis is, it won't be of any advantage. The objective of this study was, the primary objective of the study was to evaluate efficacy of KMC in reduction of the serum or the cutaneous bilirubin in term as well as preterm neonates. Whereas the secondary objective was the role of KMC in reducing the duration of the phototherapy. The studies were all of them are randomized controlled trial and quasi-randomized trial. Participants were healthy preterms and term neonates admitted in the NICU or the surgical NICU. And the intervention used was KMC to the neonates of any gestation age prophylactically or therapeutically. Phototherapy was used as a standard of care in both the groups. Outcome of the reviews were based on outcome of the phototherapy or the duration of the cutaneous or the serum bilirubin level. The literature search was done in various done for various randomized controlled trials by searching the Cochrane Review Central Register for controlled trials, PubMed, Embase, ongoing clinical trials, and abstracts of the conferences. Selection of the study was done all or randomized and quasi-randomized trials fulfilling the set inclusion criteria. Two review authors screened the titles and the abstracts of all the relevant studies. If eligibility of the inclusion was unclear for the abstract, full text was screened. Data extraction and management was done by population, intervention, control, outcome format. Risk of bias was evaluated by two independent authors as per criteria in the Cochrane Handbook of Systematic Reviews of Intervention. Methodological quality assessment of the included studies were adequate randomization, allocation, concealment, blinding of the parents, blinding of the caregivers, and blinding of the assessors of the outcome, but also completeness of the follower. The risk of the bias assessment for each included study was categorized into risk of selection bias, performance bias, detection bias, attrition bias, reporting bias, and other sources of bias. Trials that met all the criteria were categorized as low risk of bias. Those that met none of the criteria were high risk bias, and others were classified as unclear risk of bias. Two of the study excluded were Summer et al., where 15 neonates with hyperbilirubinemia were studied, with the gestation age ranging from 35 to 40 weeks, with the birth weight of 2 to 3.75 kg. Neonates with physiological jaundice and breastfeeding associated jaundice were included in this study, of which 28 neonates were in the KMC group, where phototherapy with intermittent KFC was given, and 22 neonates were in the control group, where only phototherapy was given. Duration of the phototherapy was significantly less in the KMC group, but it was being a prospective observation study was excluded from the review. Chandel and Jeju had also conducted a study, which was a randomized controlled trial, which is also an ongoing study in India. Hemodynamically stable neonates ranging from age of 30 to 40 weeks with a birth weight of 1 to 2 kg were included in this. Major congenital malformations in the form of hemodynamically unstable, requiring exchange transfusion, jaundice in first 24 hours were excluded from the study. A control group with a conventional phototherapy where 24 hours was given. An interventional group were given phototherapy with the same settings along with 1 hour of KMC every 8th hour of the phototherapy. Mother or the caregiver who was giving a KMC was provided with a chair. A phototherapy panel was held against the back of the baby in a shielded area with the room temperature maintained between 25 to 30 degrees. And the primary outcome in the form of duration of phototherapy, and the secondary being duration of the hospital stay, rate of fall of total serum bilirubin, temperature maintenance, and weight gain per day were monitored. The findings that were seen were significant reduction were found in Rosula and Lindington study, whereas no significant reduction was found in Gudravant study. Whereas the duration of phototherapy was significantly reduced in Gudravant and no significant reduction was found in Lindington and Rosula. This is the first systematic review to determine the role of KMC in management of neonatal hyperbilirubinemia. The strength being extensive literature search and inclusion of the maximum number of studies, whereas the limitation were very small sample size in all the trials, and significant heterogeneity in between the studies regarding population, that is in the form of term, preterm, and the preterm neonates, whereas also the late neonates. Intervention, wherein during the duration of the KMC observed, bilirubin measurements in the form of glutinous or serum bilirubin, and management of NNH in the form of prophylactic or therapeutic. Heterogeneity limited the generalizability of the data. Quantity of this study. The implication of the study into day-to-day practice was the KMC is associated with lower serum bilirubin level, possibly via enhanced gastric motility, increased stool output, and decreasing enterohepatic circulation. Particularly important in the developing countries where simple measures can reduce the cost of the treatment and socioeconomic burden. The implications of the research was that KMC may be a novel strategy in the management of NNH. Due to small size and heterogeneity between the trials, current evidence is not sufficient. Large trials with adequate sample size are needed. Thank you.
Thank you. Excellent presentation. Now, may I request our expert, Dr. Nandakishore Kabra sir, to come forward for his expert comments on this article.
So very well presented, Dr. Amrita. Actually, I'll just share the story how we did this systematic review. One of our DNB trainee, Bhavandeep, had an idea during rounds. So he asked, like, does KMC helps in many things? Does it helps in reducing the jaundice? I said, like, why don't we try searching PubMed and find out whether anybody has done a study like this. We all need to remember basically that, like, KMC, we know that primarily reduces mortality, late onset sepsis, improves breastfeeding, etc., etc. But there are likely to be some additional benefits, like, if you are having good GI motility, decrease enterohepatic recirculation, and it may work that way. When we looked at systematic review, very few studies, 3 from Iran. And also when you actually read, you realize that there are lots of limitations in the methodology. And the way the randomization has been done, the masking has been done, it's very, very unclear. Whenever we actually read any systematic review, we need to go through certain questions. So first question is whether the review address a focused clinical question, like whether KMC reduces jaundice, and did the author look at the papers which are relevant, like RCTs or observational studies or other types of studies? And do you think some studies may have missed or not? If not, then it's good enough. And then look at the quality assessment of the studies and whether it is possible to do a meta-analysis by combining the data. And if you are able to combine and you generate an estimate and that you can actually apply in your practice or not, that actually, like, might be helpful. Now, it is always a good idea. Amrita, would you be able to, Dr. Amrita, would you be able to share your screen and open a browser?
Dr. Amrita, unmute kara. Please unmute yourself.
Yes, sir. I'll do.
Just share your screen and open any browser like Google Chrome.
Is it visible, my screen?
Not yet.
Sir, which slide you want?
No, I just wanted if somebody who can open the browser just to see how actually you do the quick search even after reading the journal. Just I wanted to demonstrate.
Okay.
So I'm not able to do it.
Ma'am, I'll do that.
Yeah.
Host madam kara. Pale madam jara browser open kara.
वो करते सर आणि सर्च काय करायचं ते सांगा. I'll do that.
So you,
Sir, want to share the same article?
No, just open any Google browser or anything. Just open the browser, okay, and just type there PubMed, PUBMED. Okay, so single word PubMed, PUBMED.
Yes, PUBMED.
MED.
END.
Yeah. Okay. Okay, so click on that, the first blue PubMed there.
Yeah.
Okay. And once the browser open, just type there KMC. Okay, give a space and type hyperbilirubinemia. HYPERBILIRUBINEMIA. Okay, and just click search. So if you quickly see, you see there are 7 results you are able to see there.
Yeah.
So it is always a good idea whenever you are presenting the article, try to put some terms related to your question and find out. And if you just browse through one of them, the one on the top is the first study is comparing the effect of kangaroo mother care and massage on the bilirubin. The next one is the systematic review Dr. Amrita just read. Then go down. Third one, effect of kangaroo mother care. So click on that. So you would see that this study just recently published in January. The one you are mentioning, that study in progress is already published. Go little down. And what they are actually saying is that basically, like, they randomize babies who are between 30 to 40 weeks, 1 to 1.9 kilo. KMC was given 1 hour every 8 hours, along with phototherapy. And then actually we have to read full paper to see actually how they did phototherapy with KMC. So, but it was only 1 hour every 8 hours. That means 3 hours in 24 hours. And what they actually found is that the duration of phototherapy is reduced from 39 hours to 19 hours.
Right.
Okay, so again, go back to the browser.
So, sir, I have actually read this study, and what they had done is they had given the eye shield to the mother also. And on the back of the baby, they used to continue with the phototherapy.
Yeah. Just open the browser again and just type CASP checklist. CASP checklist. Okay, and just click the second one. So click on the CASP checklist. Okay. So one on the top only. Open the one on the top. Okay, so here you will see critical appraisal skills program. So if you want to read journal thoroughly, then this actually is a critical appraisal skills program where when you look at any paper, you'll find checklists for randomized trial, checklists for systematic review. So whatever I was talking, if you like, you can download the PDF, or if you are reading the paper, you can print and fill. So the checklists are for RCT, systematic review, qualitative studies, cohort study, diagnostic studies, etc., etc. And also, if you can just type, so finish this, just type Equator network. Sorry, Equator, the second one, Equator network. Okay. Okay. So yeah, click on that Equator network. So this is another very nice site, which actually gives you guidelines. How do you actually read RCTs, observational studies, systematic reviews? And you will find there are more than almost 500 guidelines of reading various things. So I think from my end, this is it. So the take home message is that, like, KMC, if you are able to do in mild to moderate hyperbilirubinemia, along with phototherapy, it's a good thing. When it comes to the severe hyperbilirubinemia, where you don't want your baby to be out for phototherapy, then it's a different thing. But we know that even if you have very high bilirubin, you are going to get this baby out maybe for feeding or for changing the nappy. That time KMC can be done. But don't think it's alternative to phototherapy. It's a complement to the phototherapy. So that's it from my end.
Okay, sir. There is a question in chat box. Dr. Pramod Wankhede, sir, Raigad IP president, want to is it possible when a high level of serum bilirubin, when continuous double surface phototherapy is required? So KMC can be used for this high level of bilirubin as well as
generally, what the article clearly says, that it should be used for mild to moderate. And when you are actually dealing with 20 plus bilirubin and you are worried, if you are having high degree of hemolysis, we should exercise caution. Having said so, although we say continuous, meaning it's not always continuous, the baby, and what is actually done in these studies is KMC for maybe 45 minutes to 1 hour every 6 to 8 hours. So that is definitely possible.
So thank you, sir, for your inputs.
Question, please.
And yes, Abba sir, please.
Sir, what is the key factor in KMC which helps the baby to decrease the number of hours from 39 to 19 hours?
Actually, I think Amrita, while reading the paper, elaborated 3 things. Number one was because it improves the feeding, it improves the gut motility, decreases enterohepatic recirculation. And also some of the authors have hypothesized that when you actually hold the baby close, it might motivate the GI motility.
Yeah, madam.
So these are kind of
madam. Few of the first slides, one is saying that the side effect of the phototherapy is increased, basically diarrhea.
Right.
Yes.
That diarrhea is going to help to decrease the bilirubin level. Then the same thing is happening with kangaroo mother care because there is increased motility and the things are getting. So how does 1 hour of a phototherapy will make a difference of almost around 10 hours of a phototherapy, decrease in 10 hours of phototherapy. More
So
than
1 hour of kangaroo mother care.
Yeah.
1 hour of kangaroo mother care.
1 hour of kangaroo
hourly.
mother care, 39 hours of phototherapy has gone down to 19 hours.
Right.
Yes.
Another mechanism mentioned, there is a vibration
So
pass from the
29
mother.
hours is a big difference, madam.
We have to realize that these are small studies. These are not blinded studies. And that's why the systematic review says we need large RCTs, which are done systematically, will eliminate the biases. Obviously, kangaroo mother care and phototherapy, you cannot blind those, but at least the selection bias, performance bias, detection bias, those biases can be eliminated. But imagine you have such a benign intervention to do.
Yeah.
How many babies are there who are having severe hyperbilirubinemia?
Right.
If you are having, say, 90% babies with mild and moderate, giving kangaroo mother care for 1 hour, half an hour in 6 hours,
Right.
your parents will be more happy with you.
Right.
Yeah, definitely.
Thank you, sir. Over to Dr. Chitra. Thank you, Amruta, for very well presenting this first article. And you are moving ahead with the next speaker. Thank you.
Yeah, thank you. And friends, our second topic of discussion is equally interesting. May I invite towering personality, yet so humble, our Maha-IAP EB member, Dr. Samir Sadavarte sir, to introduce our second speaker, Dr. Anne Mary Thomas.
Thanks, Dr. Chitra madam. You have
please
mentioned.
Share the slide, Pallavi ma'am. Yeah.
So Dr. Anne Thomas, she is a pediatrician currently practicing in the Mulund area, and she has passed MBBS from the Kochigiri MOS Medical College from Kerala, and has done the diploma in child health from the Christian Medical College. And she's aspiring for and preparing for the DNB now. So over to Dr. Anne. Everything yours now.
Thank you, sir.
Please start yours.
Is it visible?
Yes, it is visible. Yes, and you're audible well also.
Thank you, sir, for the introduction. Good evening, respected pediatricians. I will be presenting today on an article that deals with a very common condition that we see in general clinical practice. So we will be going by the titles of background, the justification of the study, the research question and objectives, the methodology used, the statistics and results from the study, the application of the study in common pediatric practice. So the condition that we are dealing with here is neonatal cholestasis syndrome. Neonatal cholestasis syndrome, as we know, is a common hepatobiliary and metabolic dysfunction in neonates and infants, and its timely detection followed by rapid stepwise evaluation to determine etiology is very crucial. So identifying causes which are amenable to medical or surgical intervention helps optimize the outcome. So in a study done in the Journal of Pediatric Gastroenterology and Nutrition in 2004, they had studied 100 infants, and in that had found that there are extrahepatic and intrahepatic causes of neonatal cholestasis, out of which in the extrahepatic category, biliary atresia was the most common, and neonatal hepatitis was the most common in the intrahepatic category. So our study that we are looking at today is titled The Neonatal Cholestasis Syndrome, Etiological Spectrum and Outcome Analysis, a single center study. This was done in Christian Medical College, Vellore. It was a retrospective study done over a period of 10 years. So the justification to conduct the study, as described earlier, this is a common condition that is seen among infants, and a good knowledge of the etiological profile will help in guiding patients in diagnostic workup and better management. And as we have all seen a change in spectrum in the underlying etiology of neonatal cholestasis syndrome, primarily because of diagnostic tools and criteria that have changed over time. And also, no similar study is available with such a length of time and a duration being 10 years and done in 300 infants. So the research question this study addressed was the incidence. What is the incidence and etiological profile of neonatal cholestasis syndrome in this tertiary center and the 10-year survival outcome? Now, a null hypothesis is in observational and descriptive studies is not mandatory, hence we look at the research question. So the objectives of the study, the primary objective was to assess clinical profile, etiological spectrum of infants with neonatal cholestasis syndrome followed up over 10 years. The secondary objectives, the first one was to assess outcome of intrahepatic, especially the idiopathic hepatitis group in terms of liver function and growth, and also to see whether the multivitamin therapy influences better growth and survival. The methodology used, as described earlier, this was a retrospective observational study done over a period of 10 years, January 2008 to December 2018. It was done in Christian Medical College, Vellore, that is a tertiary care referral center in South India, and all the information was obtained from hospital records. Inclusion criteria included infants diagnosed as NCS in outpatient service or admitted during the study period, and exclusion criteria was all the infants presenting post-surgery to the center. As we know, parents come to us after seeing a pale stool color and a clinical presentation of a child like this, and most of the time our diagnosis is based on biopsy results. So keeping that in mind, an ideal diagnostic approach was described in, again, the Journal of Pediatric Gastroenterology and Nutrition, which showed that ultrasound and scintigraphy were the first step that we take when we see an infant with clay-colored stools and high-colored urine. Scintigraphy is optional, and if the ultrasound is not just suggestive of biliary atresia, we work up for neonatal hepatitis. If the ultrasound shows a choledochal cyst, choledochal lithiasis, then surgery is planned. And if the ultrasound is suggestive of biliary atresia, liver biopsy is done, which might either show neonatal hepatitis or it might confirm biliary atresia, which can further be confirmed by a preoperative cholangiogram. The cholangiogram may or may not corroborate with the biopsy findings. So it still can provide us with two results of neonatal hepatitis or biliary atresia. If biliary atresia is confirmed, the intervention we do is Kasai portoenterostomy or liver transplantation. The workup for infections includes ruling out bacterial, viral, protozoal infections or congenital syphilis, and the various infections are described in the slide above. So keeping all these in mind, the metabolic workup for neonatal hepatitis includes workup of the urine, blood, sweat chloride, eye examination, bone marrow biopsy, muscle biopsy, liver biopsy, and genetic studies. So these were described in the Journal of Pediatric Gastroenterology and Nutrition in 2004. So keeping all these in mind, the methodology assessed the clinical outcomes in non-surgical patients with NCS with a minimum of 6-month follow-up, and prior approval was obtained from the ethics committee and admin authorities of the hospital. The various etiologies that we have just seen were considered and appropriate investigations were looked at. So the results of the study, it was found that there were 300 infants that had presented in the 10-year period, out of which 210 were male infants. 232 infants were identified as intrahepatic versus 68 infants in the extrahepatic or obstructive jaundice category. Baseline demographic characteristics were equally dispersed between two groups. As we can see, birth weight, term, gestation or not, and male or female were considered, and p-value of less than 0.05 was considered significant, and we see that the difference was not significant in the present study. Etiology was studied under two headings: intrahepatic or non-surgical etiology and extrahepatic or obstructive etiology. The intrahepatic etiology included 232 infants, out of which 54.6 had idiopathic causes, and the rest were categorized according to the various etiology found. Biliary atresia was found to be 21.3% of the total number of infants studied. Then the results that were studied were the growth and biochemical outcome at follow-up, of which 95 records were found could be followed up to 23.5 months of age. So the weight centile and the height centile were looked at, which showed a significant improvement. Again, a p-value of less than 0.05 was considered significant in this case. As LFT was also studied, and as we see, LFT also showed improvement at the last follow-up for the infants who had presented to the center. A comparison of hepatobiliary scintigraphy to the intraoperative cholangiogram was also done. And as we can see, where in cases where HPS was suggestive of biliary atresia, 45 of them, in 45 of our patients, intraop cholangiogram was also suggestive of biliary atresia, while in 17 of them, the intraop cholangiogram proved otherwise. So this showed that there was a sensitivity of 90% in hepatobiliary scintigraphy in diagnosing neonatal hepatitis. So a consensus report in Indian pediatrics in the year 2000 also showed a similar report, which showed that intrahepatic causes contributed to 53% of the neonatal cholestasis syndrome patients, and extrahepatic causes contributed to 38%. For critical appraisal of this study, I had used an NIH tool, the National Institute of Health tool, for critical appraisal of observational studies. This looked at 15 questions and assessed whether the study was a good quality study or not. So the questions included was a research question or objective clearly stated, which we know was yes, and the population was clearly specified. Participation rate was more than 50%, and all the subjects were recruited from a similar population during a similar time period, and inclusion and exclusion criteria were pre-specified and applied uniformly to all participants. So there was justification for the sample size. The exposure of interest measured was measured, and time frame was sufficient. It was run over a period of 10 years. Did the study examine different levels of exposure? No, because this was a retrospective study. Further questions could not be asked. Were the exposure, that is, were the independent variables clearly defined? Yes. And since there was follow-up, the exposures were assessed more than once. Outcome measures were dependent variables were also clearly defined. The assessors were not blinded to the exposure status of the patients, and follow-up was 20% or less. So according to going by all these questions, this was a good quality study. Now, how do we apply the study in practice? This is a good descriptive study reflecting common etiological causes over a 10-year long period. So, and in that we have seen that neonatal hepatitis is the main differential diagnosis, as opposed to the common idea that biliary atresia is the most common cause. Spectrum of NCS brought out in the Indian scenario, and this is likely to sensitize our diagnosis and early referral for early intervention. Early intervention is the very key to favorable outcome in these cases. Understanding abnormal stool color to indicate biliary atresia is very important, and practicing pediatricians and mothers need to train their eyes for the stool color chart, which is the very first step to early diagnosis. We have also seen in the study that there was no significant benefit demonstrated in administering B-complex vitamins. However, perhaps fat-soluble vitamins like A, D, and K were more useful. Thank you. Further questions can be asked if.
Thank you.
Dr. I have one question. Hello.
Hello.
Yes.
How to monitor this patient? We said that almost 68% non obstructive hepatitis initially, right? How to monitor this patient? Like 60 to 80% patient have the good follow, good growth parameters and other thing. But how to monitor this patient? Whether regular investigations required to do this in these patients? Because a 60 to 80, almost 50 to 60% is idiopathic this neonatal cholestatic hepatitis. Or whether they should be monitored other than giving ADK, fat-soluble vitamins.
So according to the study, monitoring has been done based on the growth and height centile over the follow-up times and the liver function tests. Liver function tests have been monitored more than once. Every time they have visited the OPD, a liver function test was done. So this was a monitoring that was used in this study.
Okay, so one is the all this orthopedic, this parameters, growth parameters. what are the biochemistry? Liver function test should be monitored, right? Like that.
Yes, sir.
Be specific क्या मुझे पूरा टेस्ट करना है क्या कैसे करना है?
I think our expert should comment upon this. May I request Kabra sir for the expert comments?
So first of all, like, very well presented, Dr. Ann. Was it your thesis or project there?
Yes, sir. And we had published it in the Journal of Clinical and Diagnostic Research after.
So I had, Samir had sent me the complete paper.
Yes.
Would it be possible for you to project your figure 4, table 4 from your paper?
Presentation. From the presentation, sir? Yes, sir.
If it's in the presentation or otherwise the paper, the figure 4 or table 4. So go to figure 4. Now I have one question here. So you started with 300 subjects, and then you had 232 intrahepatic and 68 obstructive. Because 110 had a follow-up less than 4 months, you deleted them from your study. But the numbers don't add up here. So if you have 95 in the follow-up data, and then you have 12 either death or DAMA or transplant, and there is a gap of 17 there. So where are these 17 gone?
So those 17 for which records could not be found for the later follow-up.
We should mention that.
Yes, sir.
Because these numbers don't add up there.
Yes, sir.
Then can you go to the figure 7? Okay, so when you look at any diagnostic test, here you are taking intraoperative cholangiogram as the gold standard or reference standard, and hepatobiliary ultrasound as a screening tool. Is that right?
Yes, sir.
Okay. So whenever we deal with a diagnostic test situation, there are certain stringent guidelines which are given. When should you actually use these kind of things? Both tests should be done simultaneously without knowing the results of each other. What actually happens in real practice is that you do ultrasound first and then you do the more invasive test. So actually it is completely those who read methodology will find it inappropriate to use this kind of statistics in this kind of paper. If it is a diagnostic study, you have to have both the tests done simultaneously without knowing the results of each other. Otherwise, the first test will lead to the verification bias with the second test. So they would say that, whether the test is accurate, reliable, reproducible, simple to perform, quick turnaround time, whether it's an independent blind comparison or not, so on and so forth. Now, apart from this, I think, rather than applying the NIS tool, it is better to apply the CAST tool. Sample size in this kind of situation is not possible, although you said that you use sample size because it's a sample of convenience. You are looking at the retrospective data and you don't have a choice there. But perhaps this would be one of the largest series in India. So meaning because you are, how many cases one would see, maybe 3 or 4 in a year in day-to-day practice. So having a cases of 300 cases, it's a huge number. So wonderful work. Now coming to the question, how do you actually monitor these babies? Usually, once you rule out that you don't need to do surgical intervention, by and large, the treatment, and you rule out there are no metabolic causes. In current era, the workups are more extensive, as you pointed out in your presentation, that these days we do newborn screening tests, tyrosinemias are picked up, fructosemias are picked up. Although the torch, it's something which is reduced, but still there will be some centers where you will still find large group of infection. So these babies are usually put on UD-Leave, 10 milligram per kilo per dose twice a day, or 15 milligram per kilo per twice a day, and ADEK, and then monitoring may be done every month or 1.5 months. And there actually if the baby is otherwise well, you don't necessarily have to do liver function test every month or so. You just monitor the direct bilirubin levels. periodically. And maybe every 3 months you do the full liver function desired. If there is any deterioration, you might do it earlier. I think that's it from my end. But anyway, very well presented and very good, but you needed perhaps some help from good methodologists so that these small anomalies which are there in the paper, which normal people will not pick up, but those who read methodology would easily pick up.
Thank you, sir. And now may I request our Guru, Dr. Mohanty sir, to share some recent updates, because this is quite a long study of 10 years. So what else is required? Can we know it from our Guru, Dr. Mohanty sir, please?
Thank you, Chitra. This is a very good study, as Dr. Kabra has already pointed out. It's a good number counts. And the other study which was published in the Indian Pediatrics, actually they pooled the data from all of the country. It is mainly contributed from PGH Chandigarh, All India Institute Delhi, then Chennai, and Coimbatore. All these 4 or 5 places where our pediatric gastroenterologists are located. So these results are also eye-opener. What the follow-up for the obstetric cases, immediately this will go for the obstetric feature, just go for a surgery, no doubt about it. And if it is done within, say, 6 weeks or so, the result is good. Otherwise, you lose the battle. Then they land up in the liver transplantation, which is not affordable by our poor people. In the recent advances, the last 2 decades, genetic etiology is elucidated for many cholestic diseases. They like just next generation sequencing, whole exome sequencing, and whole genome sequencing. These allowed rapid and cost-effective diagnosis compared to blood biochemistry or liver biopsy. As you see, if it's a neonatal hepatitis, you see a giant cell or the ballooning of hepatocytes and the pulling of bile pools, or you will find those things are actually self-limiting. And metabolic group has to be intensely looked into to be ruled out. Surgical cases, of course, I have said that we should go for surgery if at all Kasai is, it should be early. Advances made in understanding the risk factors like nutrition, the TPN associated cholestatic liver disease is also there, should be ruled out. Exact cause of biliary atresia, least understood till date, which cause we do not know. The median age of hepatoenterostomy still is more than 60 days. So this we have to improve upon. Biliary atresia remains the primary indication for pediatric liver transplant till date, and liver transplant what is happening from Delhi to Chennai, mostly on the biliary atresia. Several emerging therapies might reduce the bile acid load to liver and improve outcomes if we intervene early. And not much to say, Dr. Kabra has covered everything, but what Ayan has also highlighted, that everybody should train their eyes in the stool color. If you say stool, sometimes you can have biliary atresia where the stool is, there are some pigments, the intestinal surface cells, they laden with the bilirubin, and it is shreds the stool. It may look patchy, somewhere yellow, but if you cut the stool, formed stool, you find the pale stool in the middle. So that is should not be taken lightly. This should be different times you have to observe, and the portion of the stool one has to observe. And we have biliary the charts also. Stool charts are there. So this should be popularized in the rural areas. That is another way to a community-based approach. Thank you.
Sir, what is the role of liver biopsy in idiopathic neonatal cholestasis? So I'm struggling for the diagnosis. So 50-60% patients are going to be idiopathic. We don't know the cause. We don't know other these sepsis and our metabolic disorders and other things. What is the exact role of liver biopsy then? There should
I know, please show those biopsies. I can tell you. It's very interesting. See, in neonatal hepatitis, the giant cell on the ballooning hepatitis, the vague signs will be there. They are self-limiting. But biopsy is also not a confirmatory diagnosis of like biliary atresia. In some other conditions, you make mixed picture like this. In this side, you can see this. This way, you can there is a giant cell here. You can see mirror image. You can see. And next, are you able to see my pointer? No. I just show this one. Please enlarge it. Yeah, you can see this bile pools. Here, biliary bile duct has come. Intrahepatic biliary radicals are dilated, added with bile. And the other way, you can see the fibrosis or occurred, the cirrhosis has occurred. If it is delayed, cirrhosis can set in. So these are the histopathology. The eyes should be trained in histopathology. The person should be regularly doing neonatal liver or say pediatric liver histopathology to report it very confidently. Otherwise, it will mislead us. So that's it. It is not a confirmatory diagnosis by liver biopsy, but the other way, if you give the operative cholangiography or the ultrasound, we say the there is a some I'm forgetting. That's a Y shape. What is that, Dr. Kabra? There is a Y-shaped white structure comes. Let's say triangular. Sorry, triangular sign. That is called
tricot sign.
Tricot sign.
Tricot sign.
Triangular sign, something like that. That is very pathognomonic of biliary atresia.
Triangular cord sign.
Cord sign. Yeah. This is triangular cord sign. So that's it.
Sir, my question is to you. Sir, my question is to you. When the baby presents with us with hyperbilirubinemia, and we know that the baby is stable and high colored urine with pale stool. So how to go with this patient?
Very good question. You must tell them if the urine stains the diaper, it suggests a conjugated hyperbilirubinemia. And then
how much vitamin K we should give, and what about other vitamins? A, D, E.
No, I'm coming back. See, this is the question of the bile is not reaching the intestine. So that's why your vitamin, which are fat soluble vitamins, they're not getting absorbed. So they need supplementation. Not only vitamin K, D, E, A, K, everything. So vitamin K, as a routine practice, we give 1 milligram. If the child is actively bleeding, you can repeat the next day another 1 milligram. But otherwise, when it will not help. If you give repeated doses, doesn't help. 1 milligram in the routine for all babies. But the bleeding baby, you can consider giving you can dilute and give IV. You can immediate action you can take. And you said how to monitor. Monitor is you should not wait for monitoring sake. You should go for surgery early. And the urine color is very, very important. The mother should be told to monitor the color of urine. Conjugated is more than 20% of the total bilirubin. The conjugated fraction, 20 to 30% is more than that. It is predominantly conjugated hyperbilirubinemia. And in that age, mostly in term babies, you get this. And baby otherwise looks normal. He's not that sick like a neonate who is having sepsis or say because of sepsis. He's depressed. So he will not get. But this child will be playful also sometimes. You can see unless he going for decomposition of liver. So that's the difference.
Thank you, sir.
Okay.
Yes, sir. Dr. Jay, any other questions?
Sorry, a peripheral setting, I don't have this hepatobiliary scan or other advanced investigations or biopsy. Whether there's Gardinal will help to differentiate between the neonatal cholestatis, intrahepatic and biliary atresia. Whether can you throw light? Give some tablet Gardinal and monitor that urine color and other thing or stool color.
Okay, we see Gardinal was thrown away earlier. So again, it was reinvented. It also works. But ultimately, if these are kind of a Gardinal depressed, you will not suck the baby. Baby will not take the feeding. So we don't. Also, it helps little excretion. But here in this case, it's an anatomical problem. There is no way out. even if you give little stimulate liver, guardianal, where the bile will go? It is obstruction is there. It will not go. It is not useful. So this is not, there is no question of delaying that. Then you give some treatment, the parent will have a tendency to delay it. Let me check this medicine the doctor have given. Let me try for some days. Then they lose the battle. So if it is a biliary atresia, you should go for surgery early. And nothing like, histopathology is not done in rural areas, peripheral areas, because the report which we will get, it is not to be relied upon, because that eye is important than the machine. They should be doing it very frequently. They will be trained on pediatric liver. So if not that, so you get all fallacious reports. So we don't believe. What I find in our place also very skeptical. And then no other parameter is diagnostic. Scintigraphy is not done. You have discarded. We don't do it. This is not cost effective. So high-fi tests are not required. Stool color, urine color, and if you find that it is jaundice is progressing, and do a urine examination, you know whether bile salt, bile pigment are there or not. You can give a lead. It's biliary atresia. Or colitic cyst, your hand or your ultrasound will tell you. Ultrasound triangular cord sign, why I was forgetting that time. It is a diagnostic. It is a pathognomonic. If I get by ultrasound, triangular cord sign, a trend radiologist will tell you this is biliary atresia. So you should refer it timely to a higher center, either for surgery or if there is undergone cirrhosis, go for transplant.
Yes, sir. In periphery, we get late referrals. That is true. And usually second or third month baby we see in the practice.
Yeah. Still it is salvageable. It is 6 weeks before if it is salvageable. Ideally, it is if there is after 3 weeks, it should be done. Faster is better, still better.
Yeah, sir. What about cystic fibrosis and alpha-1 antitrypsin deficiency, which is otherwise commonly seen and maybe the cause of this neonatal cholestasis syndrome?
Alpha-1 antitrypsin deficiency is not seen in this country. Whatever diagnosis is coming is fallacious. That gene is not available, not seen in this part of the world. So alpha-1 antitrypsin deficiency in biopsy, they will say intrahepatic globular pass positive diastase negative deposits. So that kind of a staining facility diagnosis, the disease is very rare. So we will not diagnose alpha-1 antitrypsin deficiency at all in this part of the world. So it is not there. As Amrita was saying, Ann was saying, actually neonatal cholestasis syndrome, actually not, she said, it is not 100 cases, is not the fact. It is 100 types of disease conditions will present at neonatal cholestasis syndrome. There are 100 conditions we can present this. So it is not that simple. You should rule out infections, parental infections, rule out the metabolic conditions, and then whatever is left out, you do a ultrasound examination first, and go for a physical examination, colorectal cyst. So these are the surgical conditions, obstetric causes. So management becomes rather more simpler. Then think about the rare conditions, metabolic conditions. Is it not rare or all rare? Common things are common.
Yes. Any other questions, Dr. Jay?
A lot of questions, but we'll finish in the time today.
Okay. May I request Dr. Sanjeevani More to give vote of thanks? Dr. Sanjeevani?
Yes, ma'am. Thank you, ma'am. It gives me immense pleasure to thank today's guest of honor, Dr. Ramakant Patil, sir, for blessing. Today's expert, Dr. Nandakishore Kabra, sir, and Dr. Nimai Mohanty, sir, for guidance. Today's speaker, excellent speaker, Dr. Amruta Baviskar, ma'am, and Ann Thomas for excellent presentation. Dr. Hemant Gangulia, sir, Dr. Samir Sadawarti, sir, Dr. Pramod Wankhede, sir, Dr. Jay Bhandarkar, sir, Dr. Abasai Patankar, sir, and Dr. Chitra Kulkarni, ma'am, and respected senior colleagues and friends. Thank you so much for attending this event.
Thank you, Pallavi, for a flawless guidance.